Surgery is the only curative modality in approximately 80% of patients with localized colorectal cancer. But even patients who are not candidates for curative resection can benefit from surgical palliation for symptoms related to obstruction caused by the primary tumor. 8 to 29% of patients with colorectal cancer present with near or complete colorectal obstruction. Acute colorectal obstruction, ACO, is an abdominal emergency due to the associated colonic distension, fecal loading, and poor general condition. Laparoscopic surgery is impossible in the emergency setting. Surgery in the emergency setting has higher mortality and morbidity compared to elective surgery for colorectal cancer without ACO. Colorectal self-expandable metallic stents, SEMS, have been used increasingly for palliation and as a bridge to surgery for obstructing colorectal cancer. SEMS might be a useful alternative to colostomy that enables safer one-stage surgery, although it is expensive and is associated with severe complications such as bowel perforation, stent migration, and reobstruction caused by fecal impaction. Transanal drainage tubes requiring only a minimally invasive endoscopic procedure have been developed for safe elective surgery to resolve these problems. These tubes have been applied for colorectal cancer with ACO at the Nagoya Daini Red Cross Hospital since January 2007. Yamada et al. Assessed the clinical outcomes of a transanal drainage tube, Dennis colorectal tube, DCT, for colorectal cancer with ACO, focusing in particular on the impact of DCT on the subsequent elective laparoscopy-assisted colectomy. Their findings are reported in their paper entitled Preoperative Drainage using a transanal tube enables elective laparoscopic colectomy for obstructive distal colorectal cancer. 1,142 patients underwent surgery for colorectal cancer between January 2007 and December 2011. This retrospective study included 66 patients with complete ACO who fulfilled the indications for DCT. Technical and clinical success rates for DCT were 93.9% and 86.4% respectively. Perforation after DCT occurred in 4.5% and the mortality rate was 1.5%. The rate of LAC was 48.5% and the rate of primary stoma was 13.6%. For curative stage 2 and 3 colorectal cancer with ACO, DCT resulted in a primary stoma rate of 13.6%, a one-stage surgery rate of 90.9%, an LAC rate of 50%, and a 3-year survival rate of 73.1%. For stage 2 and 3 colorectal cancer cases with clinical success by DCT, the one-stage surgery rate was 97.4% and the LAC rate was 56.4%. Thus, DCT achieved a high rate of clinical success and enabled safe one-stage surgery and LAC for colorectal cancer with ACO. The authors suggest that DCT followed by LAC is a promising non-invasive curative strategy for CRC with ACO.